Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello everyone and welcome to Sensei Podcast. It is my pleasure to introduce Dr. Minh Vo from the Royal Columbian Hospital in Vancouver in Canada and a good friend and collaborator over many years. Many of you know Dr. Vo because of his publications in many of the early techniques, TPing, using the cutting balloon for draining hematoma, the move the cup techniques. I mean, you name it. He's really been instrumental in these early techniques and publishing them and making them more popular around the world. So, Minh, thank you so much for spending the day today discussing in the Sensei podcast.
Thank you, Manos, for inviting me to your great podcast.
And maybe you want to give us a little outline. How did you get into CTO interventions? How did this all work out for you?
I think this is going to be a great story. So it's in 2012 when the hybrid algorithm came out, and obviously you were instrumental in that. I didn't hear about the hybrid algorithm. I specifically remember I was working in a lab in Winnipeg, and one of my colleagues just came home from CTO Summit. And he told me, he said, Minh, we don't have to learn all these crazy retrograde techniques. There's some catheter that could somehow cross the lesion and re-enter, something like that. And I especially remember at that time, the most complex things we've done in terms of complex PCI is either bifurcation or left main. And I was getting a little bit bored of those. They weren't that complex, and I wanted to do something more complex. So when I heard about this device from my senior colleague, I was very interested. So we sat down on a computer, we tried to find out what it was. Eventually we found the crossbars and from Bridgepoint. So I called Bridgepoint, but they only had 4 reps at that time in the whole US of A. And he said, Richard Rice, if you know Richard Rice, he said, Minh, there's no one up north in Canada, but if I extend my borders, I guess you're in my territory. So he talked to Chad Kugler. He actually flew up to Winnipeg in the cold winter February. And you know how cold it is at your place as well. We have the same weather. So he flew up, showed me the crossbars. And the next thing you know it, Nick Burke is online the next weekend just to give some cases, just to give a talk in his pajamas, Nick Burke. So after that, we got Tony DeMartini to my place, and most of us know Tony. He was playing Candy Crush in the background when I was working, and I know because he was never looking. Phenomenal operator. All he had to do was look up a couple seconds, tell me what to do, look down. Then I would do it. So we did the hybrid algorithm. First case was retro. We finished within 15 minutes, and I was amazed. I didn't do anything great. I just followed his instructions. And I couldn't believe we finished it. Second was dissection reentry, crossbars, finished within 20 minutes. And I was in awe. And since then, I started reading the hybrid algorithm. I try to meet experts like yourself. I'm not the first wave. I think how I see things is I'm not the first wave. You guys are the first wave. I'm 1.5 wave. I'm not second wave either. I'm in between. So I went to TCT sessions that you and your colleagues put up, watch presentations and so forth. So that's the story of how I got into CTO intervention.
Wonderful. But, one proctoring and, watching some cases, that's obviously not enough, right? So to actually get these techniques and make them your own, this was some learning process. So how will you go through that process? So
when I was growing up doing CTOs, we didn't have all these great educational tools that, especially you, Manos, have provided to the entire community. We didn't have any of that. We didn't have the podcast. We didn't have the CTO books. There was none of that. There was no systematic learning process. It's just do whatever you can, struggle through it. So what I did was I read all, if not most of the literature. So I started with the hybrid algorithm. I would look at through all the references, who did the first retrograde, Kato. I read all his papers. I read everything possible in terms of all the techniques. And then I go to TCT, all the small sessions. I don't need to look at the big sessions because I think live cases is difficult to learn if you're a beginner. I think go to the small sessions where, they have tips and tricks. They show their cases. These are regular operators who do regular cases. And then I would talk to them as well. So not just watching, but come up to the expert, say, hey, can you tell me more about this, and show them your cases. So I did, at that point, Bridgepoint actually supported me to go to Atlanta live case. And there was Aaron Grantham and Bill Lombardi there with Chad Kugler and the others. And after the live case, I show them my cases. They teach me things. So it's an interaction with the community, with the experts, watching their presentations and talking to them, getting their perspective. I think that's the only way to do it. It's hard work. It's not easy. You don't sit and you got to put in the time. You got to sacrifice some of your personal life time for these other things in order to get better.
Wonderful. And then how easy was it to convince your local environment, Winnipeg and later in Vancouver? Did that come easy? Did it require some work?
Yes, Manos, I think that's a great point because we a lot of us try to establish CTO programs. A lot of hospitals do not see the value of CTO, especially in Canada. There's really no value. Most Canadian centers, most operators perform 250 to 300 PCIs annually, so very high volume. So we don't have time to 2 to 3 hours initially to learn. We have to do cases. We're doing 8 to 12 cases a day. We don't have time to do 3 cases a day. So a lot of centers don't support CTO intervention, especially at that time. There's not a lot of data. There actually was no data for CTO intervention in terms of any clinical outcomes until more recently. So it was difficult. The only reason why I had support was I had support of my cath lab director who went to the CTO summit, saw the crossboss, and he supported it. And when he supported it, when we started to do it, that was a challenge because you want to stay away from complications because it is high, and you want high success rate. Then they start to see the utility. Then the other interventionists start to understand it. Then the non-interventionalists start to see the benefit of it in their patients. It's a very slow process, and it's not easy. But if you are adamant about it, passionate about it, I think slowly walk baby steps, and it will get through.
And then how about your level of anxiety, stress during those procedures? Has it been evolving? Were you stressed back then? Are you stressed now? How has this changed over time?
Yes. So initially, obviously, when you're starting a program, like I said, you have to convince everyone around you that this procedure you're doing, it's unconventional, because it is unconventional, what we do, that we're not hurting patients and there's value. So lots of anxiety in terms of complications and failure. Success, obviously, and needing success. So yes, a lot of failures. So you need to select your cases very well. At that time, we didn't understand case selection. Now you got a lot of tools, teaching tools to tell you how to select the appropriate cases. So yes, initially lots of anxiety. But when you start to work, it's just like any other professional athlete. You get nervous, but once you get in the game, you're so focused that anxiety just fades away. And then once the case is done, then that's a different story, depending on the outcome. But, success rate should be high with the current techniques and so forth. So initially, yes, a lot of anxiety. During the case, you got to drop that anxiety if you want to do well, just like any other intense sport, and just work through your anxiety over time.
Wonderful. And then how about, as you said, the failures and complications? Even, the most experienced operators are going to happen as, in CTO complex PCI. How do you deal with those? Do those affect you a lot now? how is your thinking and your process of dealing with the situations?
Yes, I think the two most anxious things that CTO operators get into is failure for the patients, obviously, as well as complications. When failure does occur, and I learned this, just with the community, we are not getting 100% on CTO PCI success rate. There's no way you're getting 100%, and you have to accept that. I think initially I did not accept that. Without that acceptance, it's very difficult. It's our expectation. If you expect to open every CTO, you're not going to. You will be very frustrated. So I expect to have certain success rate, and I track my own data as well, just to make sure I'm on track. So initially, failure, I was very upset, very disappointed, especially for the patients, for patient outcomes. But, over time, I learned to understand, because as we take on more complex cases, we're going to have high failure rate. And once you accept that there's going to be high failure rate, you tell the patient in advance. You don't give the patients hopes that the artery is going to be open for sure. You tell them you may need multiple procedures. And statistically, there's no 100% guarantee, especially in CTO intervention. So once that is completed, once I've grown into that expectation, then failure less worrisome, less anxiety provoking, but still a little bit upset when you fail. Obviously, we're interventionalists. If we can't get something right, we just a little bit disappointed. But once we understand the stats and the natural nature of CTO intervention, I think it helps a bit. In terms of complication, it's always difficult, obviously. And again, we have to understand from all the data, the complication rate, 3% to 6% if you're taking on very high-risk cases. And again, you have to notify the patient, these are the complications. And while we're working, I always balance the risk and the benefit. Do I escalate? That means more risk, but more benefit. Do I keep going up? Now I have to balance that with the patient's symptoms. So depending. I mean, if the patient's very, very symptomatic, and I'll tell the patient, I said, I have to escalate, your risk will be higher. The patient will help me. So I usually don't sedate the patient that much. I'll say, I'm going to escalate now. I know, what do you think? Your risk now is up a little bit. Some patients will say, yes, my quality of life is so poor, please go on. Some patients say, no, I think I'm okay, so we don't have to take such high risk.
And then if, despite all that, complications happen, how do you deal with those?
So what I do is, those cases, I will make a CD. The CD of the patient, it will be in my office here. It will remind me of the harm I've done to the patients, and what I could do to prevent it. How can I do to treat it, to prevent future complications? So once I know certain complications I've done, I'll go to these meetings, I'll see other presentation, and it will stick in my mind. So every complication, it will stick in my mind as a task to avoid it, treat it, prevent it, how you deal with it. So I always keep a rolling tab in my mind of complications. That's how I try to avoid and lower the complication. So it's still difficult. And I'm not going to lie. I think for most CTO operator, it's very difficult.
And then what did you find the most difficult thing to learn in CTO PCI? Was it the technique, the wire, the mindset? What was the things that was the hardest?
I think for operators now, the hardest is going to be a combination. Equipment is vast. Back then, we had a couple, selected wires that, we try to master rather than understand all the wires, and there were limited wires. So back then, it wasn't really the equipment because, we only had limited amount of wires and microcatheters. Now there's tremendous amount. The most difficult part is unconventional techniques. So we're not used to dissecting vessel, that you're not doing that. You're not used to knuckling wires. You're not used to that. And you have to cross that line. And I find that's the hardest for CTO operators that want to get better when I proctor. The ones who are not comfortable doing unconventional techniques are the ones who will not embrace the full CTO gambit of technique. So I think it's the technical aspect, not truly the equipment.
Okay. And then in terms of the cases that we do from day to day and the radiation you get and the back issues, how have you been dealing with that? Especially in Canada, as you said, you do a lot of procedures. How concerned are you for radiation? What do you do about it?
So some centers are more concerned than others. Personally, I'm in the middle. I'm not at one stream or the other. And we didn't have a lot of data. And I don't know if I can ask you a question during this podcast, because yours seems to be asking all the questions. But I'll ask you a question after. Since you started the work on radiation and problems for your eyes, cataracts, that's when it started to hit me, because a lot of people, I don't wear lead goggles. I just wear standard, whatever is necessary. I don't wear lead goggles. We have a shield, just like any cath lab. So I wasn't really concerned. I was in the middle. I'm cautious of radiation use, but not overly concerned. So I don't know what your finding has been, Manos, but since you started to look into it, it got me concerned. So now I'm wearing lead goggles. So can you update me what you found?
Well, people do have more cataracts and lens changes, right? And there's also, there's many other studies showing that you have potentially higher risk of cancer, things like that, although it's very small. It's very few people who actually get it, but still, compared to the population, it looks like it's probably a little increase. So it is a problem. I think the issue with radiation is it's not something immediately visible, right? You don't get the cataract until after 20, 30 years in the lab. So if you're expecting to see something acute to get your interest, it's not going to happen. So many people ignore it until it's too late and you have the problem. So the same for the lead and the spine issues, spine fusion, back pain, all these things.
Right.
But
so yeah, go ahead, Manu. Sorry.
No, I'm sorry. And then, do you use anything specific apart from the standard? Do you use Rampart or any of the other things coming up, or are you just using the standard lead and seals?
No, right now it's those just standard lead and things. In the Canadian community, we're a very small community. I have access to all the operators. I know how they practice and so forth. We all practice the same, and I'm a little bit assured that we haven't heard any issues in terms of radiation, injury, cancerous in any of the operators thus far. But like you said, it's silent. We don't know until decades later. And by that time it may be too late. So most Canadian operators are not very anxious about radiation injury, but just using standard equipment only. They don't add anything extra.
Now, in terms of the teaching, I know you've taught many people, you've proctored people here, outside the US, in several places. How do you see the people who come to learn? Can you tell when you see them that this person is going to be a great operator or not?
I think we all could tell when we were in the lab who is going to embrace the CTO path and who's not. Some people are doing it just because it's neat or it's cool or it's sexy. Some people actually believe in it and really want to learn it. I think you could tell, like I said at the beginning, it's the one who can embrace unconventional techniques, are willing to take that step over the edge comfortably. Those are the one who can embrace it quicker. And I've talked to people where I've asked them to not go, they won't. They said, let's try another wire. I've asked them to dissect the vessel. Okay, can we not? Can we switch a retrograde and not dissect? Things like that. Or should we even do retrograde here? Do we need to? So those operators, we could tell right away.
And do you think the issues are more on the mindset or in the hands, the dexterity? What is the biggest barrier to learning CTO PCI? I
don't think it's dexterity, Manos. I think initially, I think were you in the boat where you believe that CTO intervention can be taught to any operator? Were you on that boat, Manos?
Well, I thought many people can can learn it, but I know the statistics, right? 1 out of 10 of the people who are proctor actually becomes a CTO operator. So there's no way of denying that. I mean, the question is not whether they will become, because many will not. The question is, if they wanted to, could everyone do it? Because the issue is, right, the person comes to you and you look at him work, the fellow, for example, and the hands are not very good. You see, that doesn't get the coordination. And the question is, can you build it? Or if you don't have it, it's kind of a major limitation. It's not going to be a person who's going to do it well.
Interesting. I didn't know that data 1 in 10. But I thought initially when I started this, I was again in the 1.5 wave to get in. I think the first wave, especially Aaron Gantham, his thing is we could teach anyone to do CTO intervention. He was on that boat. I guess you are not in that boat now, but you may have been in that boat before, but not admitting to it. I think a lot of people truly believe they could teach everyone, and I agree with you. I don't think everyone can be taught. I think the limiting factor for those individuals, like you alluded to, is a little bit dexterity, but the other is just they have to be comfortable with being uncomfortable. That's what a lot of people say, and if they're not willing to be comfortable with being uncomfortable, they will never cross that line, and they will never be good C2 operators, and they will never do it.
Yeah, absolutely. And I could not agree more with this. But my philosophy also is that many people, as you say, you see them and you say, it's unlikely they're going to become a CTO operator. But still, going through the exercise, I think many of them might pick some things, trapping, some modifications, or some other things that may help them anyway on their CTO practice as well.
So let me bounce that back to you then, Manos. So yes, they could pick up certain techniques from the CTO gambit of techniques. They could pick them up for non-CTO things, right? So how about if I to ask you a question, when you proctor, do you believe in proctoring a CTO operator to become an absolute operator in terms of all the techniques, all the gambit, or are there different levels? There's a white belt, there's a green belt. You could do dissection entry only, but no retrograde, or just do retrograde, or just do wire escalation. Do you believe in that, or do you believe in when you learn, you gotta learn everything? What do you think? You got books on CTO intervention.
Sure.
What's your heart tell you?
Well, my philosophy has always been that you teach everyone and let them take it as far as they are comfortable taking it to. So I don't believe you withhold from someone who may not be willing to go all the way to do retrograde epicardial. I mean, if that's going to do it, that's perfectly fine. If he goes to do ADR only, that's perfectly fine. So my philosophy always has been that, you do the best you can and let people decide, whether this is something they want to pursue or not. And if they want to become undergrad only operators, I'm perfectly fine with that. And maybe that's better for them. If they want to become full masters of the technique, that's great too. But, I don't think you can, I think all of us, including myself, right, there's a spectrum. You always keep on growing, and sometimes, there are some limits that you're willing to take, sometimes not. And maybe you're not ready now, but maybe in a year you are, or maybe they will be. But what is your thought on the same area?
I'm confused, but after what you said makes sense to me. It's more balanced because I was very passionate in CTO intervention, very passionate, like you said. Sacrifice a lot of family time just to learn the techniques, meet the people, know the people, get into the community, so forth. I initially believed with the first wave, that passion that we could teach everyone, and you got to do it all. If you're not going to do it all, don't do it at all. Initially, I was hard iron fist that way. But over time, I don't know what to think. And I do agree with you, if they take away techniques, like trapping or guideliner or other techniques, BAM technique for their balloon uncrossable lesion, that would help patients, not even in CTO intervention. So I've done that. I've taught people certain CTO techniques, knowing they're not going to be full. I don't know what that means. That's another philosophical thing. Sure. What's a full CTO operator? So I think I'm on the same mindset as you. You teach them everything that you can, and whatever they pick up and help the patients with the techniques that we provide them.
And then speaking of teaching, you're one of the few people, as you know, most CTO operators are not really into publishing, academics, etc. But you, from the very beginning, you were very much into this, published several pivotal descriptions of techniques. So what motivated you to do that, and how were you able to do all this despite the clinical work and everything else?
Yes. So Because, like I said, when I was growing up in the CTO intervention world, we didn't have a lot of true publication on techniques. People talk about it at meetings, describe it, and there's no formalization of the techniques. There's none. Each person would hear different things from different people, do their own thing. I didn't find that very helpful for me or for the other operators. So again, I would read all the literature, talk to experts, and say, okay, exactly what are we doing with the granuloplasty? Exactly what are we doing? What balloon and how are we doing this? Because people have different ways of saying it. So I thought, you know what? Since I have access to experts like yourself, Lombardi, Grantham, let's talk to the expert from the one who created the technique and share that with the world in a formal fashion so people across the ocean could read it and learn it. And not learn from second hand or third hand. Learn it from the first hand, but through me by publishing. So that drove me. So how do I find time? Again, we're very busy, so we don't do a lot of, myself personally, I don't do a lot of, research. Unlike yourself, I don't have a mechanism to do any of that. So all this I do myself, obviously with the help of colleagues like yourself to help me as well. And it takes a while just to publish a case, but the driving point was I have to find my own time. You got to find time if you want to publish. Work time is not going to provide you that. No matter where you work. Work time is not going to provide you. So you got to find time on your own time, sacrifice some family time, sacrifice a little bit here or there, and try to balance your life and add time a little bit. So every day, if I want to publish something, I'll tell my mind, I got to get this done by the end of June. I got 4 weeks. What do I do? Every day, I add a little bit in and a little bit in. So you got to manage your time that way.
Perfect. And then from the many papers you've done, which one is your favorite? Which is the one that you're most excited about?
The most excited about? That's interesting. I think the most favorite of mine was the one with you where we talk about the BAM and we have a 50% success rate just from our small cohort, because I use that. And it has some numbers, whether it's official or not, across the spectrum of all the BAM that's been done. It does help me help my the people I proctor. I said, use BAM. 50% is going to be successful, 50% not. It's a cheap thing to use. Use it because it's so practical, manuals, and people have used it in non-intervention and they love it, and they're so thankful for it. That's the one study. The other ones is higher technique, more complex, move the cap and so forth. It's higher. It's not very practical for the common interventionalist, for the daily interventionalist. But the BAM was phenomenal, and I'm very proud of that paper.
Yeah, and just for people who may not be familiar with BAM or balloon-assisted microdissection or granuloplasty, this is a technique where the small balloon goes in and then it's inflated and bursts, and that modifies the plaque. And as Mr. said, this often is all you need, and the next balloon will go through. And that's a very simple way, very cheap in a way to get through an uncrossable lesion. So yes, thanks for spearheading that. That was, I think it's at the beginning of the algorithm. Actually, you try the small balloon. If it doesn't go, just rupture it, because it's easy to do and it might get the job done.
Exactly. Yeah.
Now, in terms of personal life, so how can you keep fit to do all these things, the cases and the research and everything else?
So people might not know, but I don't have ACL or PCL in my right knee.
Uh-oh.
Yeah, so because of that, I have lower back issues, wearing lead all the time. So it's out of necessity that I have to keep fit in order to work, in order to do CTO. So in my mindset is the only way, again, I'm very passionate about CTO interventions, and everything I do is for it, like training for the Olympics. So I work out for lower back, for strength, core, everything, in order to preserve my health, in order to do long cases. I've had long cases and I come out, I feel great. Before before CTO intervention, I didn't really work out. But with CTO intervention, we all know when we first start off, it's war against coronary artery disease. So I tell patients, this is like war. We're going in. It's going to be 2-3 hours, maybe more. I don't know, maybe less, but it's going to be a long haul. So I'm prepared to stand there for hours long. And when I didn't feel that great initially, then I have to keep fit in order to do these cases, for these prolonged complex cases.
So you go to the gym. How do you actually exercise?
So I live in Vancouver, so in the Pacific Ocean. So it's mild weather. We could bike all year long, Manos. I don't think you guys can. We could bike all year long. With COVID, I started doing calisthenics at home. And calisthenics is easy. I could do it right now in front of you, Manos. I'll do some push-up, some handstand, and it keeps me in shape. So I find that very practical. I think as C2 operators, most of us are very practical individual. We find ways to deal with things that practically. We don't waste a lot of time. We're efficient as well. Most C2 operators are efficient in life and at work. That's what I believe. So I find calisthenics is very efficient. So that really fits into my lifestyle.
And then do you do other things like meditation, other yoga things to relax your mind and keep it focused?
Oh yes. So I do meditation. I do breathing meditation just to relax and calm the mind, because we're busy at work and we need time for ourselves, for family, and we need just some peace of mind as well, just to reflect on things. So yes, I do meditation probably on a daily basis, up to 15-20 minutes a day. I'm not a yogini teaching meditation, but I just do it for myself.
Perfect. And then do you have any favorite book or favorite movie?
So my favorite book is called The Silent Warrior. So again, my mindset was pretty intense for C2 intervention. So because I relate that to snipers. So if you don't know anything about snipers, Manos, they're very intense. So in this Silent Warrior, this is the first sniper that started to teach sniping school in the US. Before there was no sniper. He would contort himself in a standing position, stand there for 6 hours and not move. They are so intense, just like C2 operator, and that really connects with me. He will lie there. He will shoot over a kilometer range. He will stop breathing, and at the peripheral, there will be a wind flag. As soon as the flag drops, he will shoot. That's how precise he is. I find that similar mentality to C2 operator. We're so precise, we're so intense that this book actually is comes together for me. So it's about this sniper that went to Vietnam, how intense his training was, how passionate he was about things, and how much he trained. So I had to train a lot for C2 intervention as well, because I'm not a natural excellent operator, but I wanted to be the full thing. Just like all you guys, I want to do every technique that people present, I should be able to do and things. So I had to go through all that. Initially, cases went long. I don't know your experience, Manos. You could tell me a little bit. Initially, cases were very long. We were learning 3, 4, 5 hours sometimes. Have you had long cases like that, Manos?
I have, and I continue to. I need to learn more, I guess.
But now the cases get shorter, slightly shorter, but still long. So I think when we work, it's very intense situation. So like you said, books help. It motivates me too. So these things motivate me because back then we didn't have, a lot of social media things and operators. We only meet at meetings. So I miss that, once a year, twice a year. So that's why I like to talk to you, Manos, when we see each other, talk to other operators, just to motivate me and say, you know what, keep up the good work. So books like this motivate me as well. So at that time, these books really motivate me to stay on top of the game. So very helpful. So so it helps for these long cases.
Yeah, that sounds great. And then actually, speaking of motivation, what motivated you in the first place actually to get into this and then keep on doing this, as you said, and it looks like it's been a life-changing experience for you and many other people, including myself. So what was the initial impetus for getting into this area?
Yes, you're right. It is a life-changing experience because without this, I think I would be almost depressed doing PCI and on call STEMIs and just doing regular cases. That didn't drive me at all. I think, again, I'm not sure if CTO operators have a different mindset. We must have some sort of mindset. We're bored of just regular PCIs. We're not stimulated enough. It's not enough, on a daily basis. So what stimulated me was, like I said, I remember sitting there almost depressed. I'm thinking, why am I even doing intervention and doing call? I should be doing something that makes me happy. So I was at the depressing point. I was 4 years out of practice. Again, bifurcation and left main were the most complex, and it's not that complex. They're open lesions. There's nothing hard about them. So when I found CTO intervention, then it's life-changing, like you said. And I hope, people listening to the podcast understand the passion and the things that CTO intervention could bring you and your patients, and just elevate percutaneous coronary intervention field. It just elevates everything.
And then, which is your favorite movie?
My favorite movie. That's interesting. My favorite movie was The Matrix, because it has a lot of meaning. Technology. I like technology, and I think, again, most C2 operators, especially yourself, now you have a podcast and you have your fancy headset and microphone. I think you have multiple microphones, Manos, because the other podcasts I've seen, you had different microphones. So I think we like technical things. We're very technical. So that's why I like The Matrix. It's about technology. It's about different in reality, all that stuff, and it's different messages to different people, and I love that.
And speaking of techniques and technology, where do you see the field going? We're now 10 years since the hybrid, 11 years, and more equipment. Mm-hmm. Do you see this is going to become simplified, get a device that will fix all and will be done in 5 minutes? Where do you see this going?
I see that, during the first wave, there was significant change. And it slowed down since then. All the equipment now is just replicas of one and another. I think the biggest thing will be for calcium. And I can't divulge any information, but I think it's there are companies out there having new technology, new way of dealing with calcium that will help us for these cases, because I think we all know that calcium poses the most complexity for our procedures, increases failure rate, and we don't have a lot of equipment to deal with it for CTO intervention. I'm not talking about shockwave, a big balloon goes in a lumen. We're talking maybe a wire shooting some sort of things to break the calcium, or microcatheter, things like that. So I think companies out there are working on that. Once you deal with the calcium, then we should be able to deal with almost, if not most of the most complex CTO intervention. I think that's where the field's going next, is to deal with the calcium. But technically, I think we could do a lot already. It's just the calcium that's stopping us.
Wonderful. And then in terms of the things that excite you right now, what are you most excited about?
CTO intervention is still exciting. I'll tell you, every day I go in, if there's no CTO intervention, my nurse will tell me, "Oh, no CTO today. You're not going to be happy." I said, "That's correct." If I could have at least 1 or 2 CTOs a day, that would make my life happy. So CTO, even if it's simple CTOs. So now, before it's all about techniques, all about me trying to have all the skill sets to open CTO intervention. I think that phase is plateau a little bit. I'm still learning, obviously. I'm not the best in the world. I'm not an expert. But my techniques, my learning curve has plateaued a little bit. And now it's for the patient. Even if it's a simple CTO and I can open it, the patient is so happy with quality of life. And we know there's data for improved quality of life. And they know there's no mortality, but quality of life is so important for them. Even simple CTOs, that gets me going every time. when the CTO is open. When the CTO is open. That gets me going.
Wonderful. And then I think you're being quite modest. I think you're one of the top people out there. But what are you most proud of in terms of what you've done, both personally and professionally?
So I think professionally, I've given a lot. I'm proud that I'm truthful to myself and the community. So I don't show cases that's a one-timer. I show cases that can be repeated, because I do believe in the original theory of the algorithm of the core group that you guys wrote with the hybrid is it has to be repeatable. It has to be teachable. So every time I give a talk or anything or teach or proctor, I'm proud that I'm true for myself. I don't lie. I don't tell them things that's not true. If I cross the one epicardial luck one time, I'm not going to show that case. I'm going to show the case where, yes, you can do this. I want to motivate people to understand my passion and their passion. I hope to motivate them because I had that from you guys and I really appreciated that. So the most thing I'm proud of in contributing to the community is showing truthful cases that's going to be repeatable and teachable. Yes, you can do it if you do this consistently over and over again. So that part I'm very proud of. The other thing I'm proud of is I got a motorcycle license. You may not agree to it, but riding
congratulations.
It just feels free. It just feels free and relaxing. So I didn't say that at the beginning. I meditate, but motorcycling is very relaxing as well. I'm not a racer. I just go nice and easy and relax. I'm not a crazy rider on there. And getting a motorcycle license takes time as well. So it's just like seat intervention. Everyone can get it for sure, but it takes time and commitment. So now for you, Manos, you're not going to have time to get a motorcycle license because you need a whole weekend, 8 hours a day, including Friday. You won't have that time, you see? So it takes a lot of commitment.
Yeah, I think it might be a little high order for me, but congratulations for getting it. Sounds like a lot of fun. And what motorbike are you riding right now?
So, do you know the types of motorbike, Manos? So
no, I don't.
There's racing, the cool kid with the leather jacket, the colorful, and just zip by. And there's the loud one, the cruiser, where the big guys sitting and making lots of noises. I'm neither one of those. I'm the one that's called the cafe racer. So it's to get you from one coffee shop to another. So it's kind of chill. It's a British traditional bike. It's kind of relaxing. It's one of those Brad Pitt kind of, style, kind of chill kind of ride.
Well, can't wait to see you on that one the next time we're at a meeting. So it sounds very fun. Congratulations.
Thank you, Manos.
So me, again, you've done many, many things over the time and you've taught many people. You continue to teach many people. If you had to summarize and give people some final piece of advice, the key things to take into account if they want to learn and get good at this, what would you tell them?
So I think just getting a proctor is not enough. Like I said, if you want to become a full-fledged, whatever that means again, CTO operator, you want to learn all the skill sets. You have to put time into it. You have to put effort. You have to have a support from the community, from the experts. Because traditionally, experts at meetings are out of reach. So when I was, first, second year, experts in left main stenting and so forth, they're out of reach. They're on the high podium. You can't talk to them. They're so busy. You don't know their contact number. You don't know where they are. But nowadays, people like yourselves and other C2 operator are very accessible. So use the community as support for cases, and you want to learn. Everyone has time for you. I guarantee that, especially the US operators. Read the literature just so you understand the literature. It's not just do. Read the literature, understand the complication, what the risk, what the numbers are. A lot of people don't know numbers. They're just going in to do it. Once you know the numbers, it's in here. and it emanates out from you. You know the numbers, you know the risk, you know the techniques. So read the literature, talk to the community experts, then go to meetings, then start to do cases with support. So everything, I think, has to come together, not just, I've seen some cases, I'm just going to do it. Or I'm just going to get a proctor, I'm going to buy one of the product, they'll provide me a proctor, I'm just going to do it. I don't think that's the great way of doing it. And if you talk to a lot of operators, you learn many different things from different operators. You're learning so much because each operator offers different things as well.
Wonderful. Well, again, thank you so much, Minh. Again, that was phenomenal.
Thank you, man.
Thanks for everything you've done so far. Congrats on everything, and super excited to keep on working with you.
Thank you, Manos. It was fun. Next time I'll ask you more questions.
Sounds great. Thank you.
Thank you.
Thank you for listening to the Sensei podcast.